Thank you. Good afternoon. And today we're going to be looking at where we at in the overall process, some sense of timelines in this journey as we continue on in this second week of intense precaution and physical distancing and the different behavioral measures we put in place. Also speaking to some aspects that we've done with public health measures, emphasizing some of the information I put out in my letter yesterday, as well as in some more information going out into the public forum later today, emphasizing the same points. We'll talk about that. Aspects around our vulnerable population, especially the over 70, and also long-term care, with the directive having gone out. And then speaking about some other aspects I think we need to pay attention to as we continue in doing this concerted effort to bend the curve for COVID-19. So before I get into those kind of comments, I'm going to ask Dr. Yaffe to talk about the data today. It's coming in from many sources in different times, and that's good, but it has its challenges in there to make sure we have consistency as best we can. And so we'll give those data points to you today. And so it gives us some idea of how some of the different sectors are performing in a certain timeline in that regard. So over to you, Dr. Yaffe.
Thank you. So at this point, as of 4 p.m. yesterday, the data in the Integrated Public Health Information System, known as IFIS, which is where public health units input the data on their cases, at that point, we had a total of 1,966 confirmed cases of COVID-19 in Ontario. This is an increase of 260 cases from the previous report. At the time of the posting this morning, there were 33 cases that had passed away, which again is based on the numbers in the database. The numbers are fluid. It's a fluid situation, and we know that our local health units are continuing to work on new confirmed cases as well as deaths that have not yet been reflected in the numbers that I've just provided. And we will provide more detail when the numbers are available. It is good to note that we have 534 cases that have been resolved. At this point, there are 291 COVID-19 patients currently in hospital in Ontario. Of those, 125 are currently in ICU. And of the 125, 82 are in ICU with ventilator, invasive ventilation. In terms of the lab numbers, we have currently at this point, the labs have tested a total of 51,629 individuals. And as noted in previous conferences, many individuals have multiple specimens tested on them, especially those who are in hospital. We have 4,280 that are currently under investigation. And in the last 24 hours, we've received results on 3,076. I'll turn it back to Dr. Williams.
Thank you. And you can see there we're making headway on the backlog and doing that testing. The numbers, you can see we're down a bit from yesterday. Yesterday was a combination of carrying out a number of backlog cases. So that's not surprising. I mentioned that the percent positivity seems to be staying about the same. So we're being informed by that. So with that in mind, I mean, where are we on this journey? And I will say that we did compare ourselves with some of the other provinces and territories and our neighbors to the east of us, Quebec, yesterday at 10, where we were at 1,300 cases officially. They had around 2,900 and dealing with other issues. And if you look at the global situation, especially to our neighbors to the south, as of today, they're at 143,000 cases, which is larger than China, and nearly 2,600 deaths, and that seems to be, unfortunately, escalating at a very rapid pace. And, of course, we continue to monitor and be concerned for especially our New York State situation there and being updated on that on a regular basis. So with that in mind, when we're looking at these numbers and people are asking, what does it mean, where are we at? And if you take that our numbers yesterday and today with our higher than last week, excuse me, as I said before, that's not surprising, but you have to look at that. We said these numbers indicate what happened almost 2 weeks ago. And that may seem surprising to people, but if you look at in the reality of it, if you had a test positive today or yesterday when we got the results back, that means it was probably in the laboratory for at least 2 days, maybe 3. That means you probably got seen at an assessment center 2 or 3 days, 2 days after you became symptomatic. That means you probably had incubated for 5 to 7 days before that. And so if you map it back, we're almost back to 11, 12, and 13 days when those people were exposed, whether through their travel or case contact. If you look at that, that means that week we're mostly concerned about, March 13, as you recall, that's when the schools had their last open day, because it was PED day. Then the school March break started. During the week of the 16th of March, we said the maximum number of people were coming back into Canada. And on the Canadian Border Security's data, that would be demonstrated to be true, with between 90 and 140,000 a day coming back into Canada through all different sources, into Ontario alone, through road and through air in there. That number has continued to drop off during the week of the 16th of March. And as you get into the end of March, it had dropped down to, the last one I had is the 28th of March, where a total of 25,000 for all of Canada came back, and of those half were Ontario at 13,000. Keeping that in mind, then, you would say if there is a steady percent of people that were positive because they inadvertently became in contact through their travels, which has seemed to be a certain percent. Not everyone coming back is infected. Let's be clear on that. And sometimes that's a misinterpretation. Yet we still require all those people to isolate, and because they don't know if they were or were not. And we ask them to do their 14 days, and we are doing our 14 days also. So the fact that we have a surge of more cases now only indicates what we would expect. That reflects back when those people were all coming back from the 16th to the 19th and 20th of March. And as a result, then, we have started to see some increase in hospitalizations and ventilation, because our data tells us that 6% of those testing positive will get hospitalized, and 2% of those will require intensive care and ventilation. So, and we should expect there's a delay between our positivity numbers and when some of those become hospitalized or ventilated, usually about 4 or 5 days. So we'll expect the number of hospitalizations and vents to increase accordingly in the days to come, because it always has a delay from the positivity, and as I said before, has a delay from the time of when they came into Canada and their time of exposure due to their travel. So I think we need to keep that in mind and saying, okay, if we keep steady at the task, keep the physical separation, keep at home, all those aspects we've asked the public on measures, because if we have people out there and around that we don't know if they came in contact with a case that might be incubating, then we've added that protection, because as I said before, if you maintain and do that, you will not be infected. And what we find sometimes now with our numbers of travel-related cases dropping, because less people are traveling, as the cases of known contacts are going up, because people become aware, have been told that, oh, I see that some friend of mine is now a case, I didn't know that. And even some of the ones we don't have the complete data that said, I don't know of any travel or any history, later on they may say, someone just told me that so-and-so I was with for 2 or 3 days is a case, I didn't know they were. And I become aware of that information. So we're trying to watch that transition and see as we get out of the travel-in phase out of the way and keep that clear. We keep our children out of schools during this time, because all I need is a few traveling children who are incubating to go back into school if it's back in again, and you've got the whole school impacted yet again in that regard. So these are all the safeguards that are in place. That's where staying the course. The schools are going to continue to be closed at this time here. And if we're going to do other things with special daycares and services related to that, though for healthcare workers and others who need to be essential services, we want to make sure we do that very carefully with proper screening for any potential risk cases in there, because we do not want that introduced back in again. So the message is be consistent with what we're doing. We're getting through this tough time right now. My letter yesterday out talked about the priority things that you need to do essentially. You will notice in the letter the things and activities I said, I didn't put in going out for exercise and walking. I would rather that's done if it's an essential part of your need, and you do it in a way that's safe. That means not going to public places that are heavily attended, not going out at prime times. Pick some times when you know you can do it and maintain your physical separation. And seen some people, on the weekend especially, had difficulty, for some reason I don't understand, doing that. It's easy to assess. You go to a place and it's busy, you don't go. You go away and go somewhere else. And so you can do that, but there are some essential needs you need to follow in that regard. Furthermore, add to the fact we're talking about the 70s, people over 70, and need to stay home at this time because if they get it, the consequences, as you see with the increase in mortality rate and morbidity rate of 70 to 80, more with 80 to 90, and more with 90 to 100. As you go older, it gets more and more higher mortality rate. It's known, the data is there. Therefore, you want to take those precautions. But that means we have to support our over 70 population to do that. That means you have to give them assistance, as we said before, in many ways to handle that. And we're trying to look at and assess that. The other thing I want to talk about is there's been some talk about people who have left to go up to northern areas, to cottages and that. It's like an extended March break, holiday, whatever in that. And while that may seem to be an opportunistic thing to do, you have to understand that puts unprecedented load on those communities if you're dealing with significant numbers. I understand that some people say, I'm supposed to go up and check it for insurance purposes, go up, stay overnight, come back home again. That seems to be reasonable. That's an essential need you may have to do. You have to check with your insurance company so that you're not defaulting. At the same time, if you stay up there, those smaller communities are seasonal. They have food supplies at their grocery stores and that set up for seasonal activity. They do not have a lot of people, normal in the normal background of the community, to look after. Therefore, when you go up there, you compromise the supply for the local residents. And you have to understand that you're putting a burden on there. Also, you have to understand in this time of era that the health services up there are set up seasonally as well. They have it for the local community. They have not surged up with locums and other people for the usual summer doubling, tripling of the population. And that's not set up for that purpose. So by going up there, when you don't have, if you're going up for extended time, you don't have access to your regular family physician or your specialist if you have complicated health conditions, and you don't have the same intensity of secondary, tertiary, and quaternary care services that you have in the Greater Toronto Hamilton area. So by going up there, you may be putting yourself at risk and putting a greater pressure on the local community that they're not ready to deal with, especially in the next 4 to 6 weeks over this time period. So I'd ask you to think seriously about that. It may be an interesting thing to do, and I'd say if you're going, just go overnight. Preferably don't go at all. But you may have reasons for your property or for insurance. I understand that, but don't use that by going up extended period of times. So those are my main messages for today. Where are we at? How are we doing? My sense is that most are doing a great job, and you're hanging in there doing that. We're getting to this period, so I'm trying to tell you these numbers so you can see and forecast where the timelines and where we're going. At the same time, those other areas I've talked about where we want to put more emphasis on as we seek if we have to ramp up some more public health measures, much like the Cabinet did with their order, much like I did with putting out more directives to long-term care and retirement homes to enhance all those aspects there, because our cases in long-term care homes is and continues to be of great concern, not for us only, all across Canada. And we're all struggling with those same issues. How do we really protect that very vulnerable population in such a way that ensures their safety and the staff safety, and also the ethics side of allowing visitation by virtual means to keep connectivity, because we want to make it as empathetic as possible, but that means we need everybody to pull together on that. So we've enhanced a lot of the things in those homes that we're doing, working with our partners in the Ministry of Long-Term Care to seek to ensure an ongoing heightened protection of our long-term care and retirement home citizens. So with that, I'm going to end and open up for questions. Thank you.
Okay, we'll take the first question.
First question comes from Avery Haynes of CTV News. Please go ahead.
Thank you for taking my call. For weeks, the messaging has been to the public that everyone should treat everyone else as potentially COVID positive, especially since so many people are asymptomatic. Why then are personal support workers not being supplied PPE in long-term care homes? We've been told at some facilities that it's being locked up and will only be released after an outbreak. And the union's calling for a directive that these facilities equip every frontline staff with appropriate protection.
Thank you. And I think if you think about that, what you're asking is saying that if we're protecting our long-term care residents in there, if all visitors have been limited and screened very carefully, and if the healthcare workers have also complied with all quarantine, if they've been traveling, and are not coming to work sick for any reason, that should be a relatively safe zone where there is not infection circulating, as compared to out in the public where there may be a risk. So if you're doing that right, you don't have to wear PPE every day. In an outbreak, you have to, because then that security around that institution either is deemed to be and proven to be violated, and therefore you have to put all that protection in place. So there's a clear difference between day to day and when you think you have a case and you move on it very quickly, then you have to move with personal protective equipment accordingly. So we have tried to put those directives out as clear as possible, such that the residents are not put at risk, and either are the staff. And that means then fairly strict dealing with visitors and people coming out, because if it gets in the home, it had to come from somewhere. That means new admissions and transfers have to be handled very carefully. That's all part of the directive. Screening visitors, screening staff, transfers in and out, and no short visits in and out, because then you can't control. And it gets introduced into the home, and then you have a major problem to deal with.
Follow-up?
Yeah, as a follow-up, I would just say that given that so many people are asymptomatic and personal support workers say they are terrified to go into work, they're being banned from wearing masks, they're only being given gloves, and they're fearful that they're on this death watch and potentially transferring COVID-19 from patient to patient. They're requesting a directive that these facilities give them adequate PPE.
So we put out the directive, excuse me, for all workers in use of PPE, because we do have to make sure we have an ongoing supply. So when you need PPE, the proper personal protective equipment, for the right procedure at the right time, we want to ensure that our healthcare workers have it. If there is a sense of apprehension in that, we understand that. If we had lots of supply to give out at any time in any way, we could deal with that. But we have to be judicious on our use of it, so that when you do have an outbreak, you still have the proper PPE to wear, and hopefully by doing all the proper processes, you won't have an outbreak. You'll keep your home clear of COVID-19, and then it's not a risk to you or the residents, unless you come into some risk when you're off the job, out in other settings, and you have to be attentive to that very much so, because your risk may be greater on the outside at times, and because you can't tell where all your friends have been and what they've done, than on the inside, unless there's an outbreak, and that's a different situation.
Next question.
Next question comes from Allison Jones of the Canadian Press. Please go ahead.
Hi, this question I think is probably best for Dr. Yaffe. I'm wondering if you have any updated figures on both how many long-term care homes are dealing with COVID-19 right now, and how many of the 33 deaths in the province have been in long-term care residents.
Sure. According to the data that I have in IFIS, which is what has been submitted by the public health units, and as I say, we recognize is not up to date. The information I have is 10 outbreaks, 10 long-term care homes with outbreaks of COVID-19, and in 11 deaths, so 11 out of the 33. Which is probably about the right proportion. I think the majority of deaths are probably in the community. But of course, as I say, the data is still not completely up to date, and we'll certainly update it when we can.
Follow-up?
Yeah, sorry. What sort of trends do you think that we're going to see in long-term care homes in the coming days and weeks, given how many homes it's in, and how vulnerable we know those residents are?
Well, I would hope that with the new directive, and I know our staff are working with the Ministry of Long-Term Care on doing more education and training for long-term care staff and retirement home staff, and working with public health as well. I'm hoping with the more aggressive measures that are being put in place and the more aggressive training and support, that hopefully will pick up cases as quickly as possible and will prevent spread as much as possible. But keeping in mind, it's a very, as we all know, very vulnerable population.
Next question.
Next question comes from Antonella Artuso from the Toronto Sun. Please go ahead.
Thank you. Good afternoon. I had a question. I was speaking to a doctor in Bobcaygeon who said that she was surprised at the rate at which COVID-19 spread through that local nursing home. I wanted to ask, is that your experience? Does COVID-19 move far more quickly through a nursing home than influenza?
So our experience is that was the one in Bobcaygeon is our first large one in a facility, so we have limited. We've tried to look at the BC situation. We have some others that are ongoing at this moment here. They're all different in their own perspective. A lot deals with a number of parts to the puzzle in that one there, as well as when we look at what was learned ahead of us. It's two of the larger outbreaks in British Columbia. We tried to understand what were those aspects, because there's many components to it. The physical plant, the layout, the staffing situation, the commingling type situations, the food services, many things all play a part in here. And each long-term care facility has its own uniqueness because they want to try and make it, for a lot of these people, it's their residence for a fair period of time. And they try to make it as facilitated that way. That in itself has some changes. It's not strictly laid out like a hospital ward, and that means you're going to have to deal with those things in a large sector in that home. So I think as we're going through it, working with our long-term care ministry and with our public health units on those different levels, dealing with the wide variety of different long-term care facilities we have, I think each one is unique in its own way, and therein lies a challenge, but that means we have to move quickly to deal with any gaps and service or some limitations if they're in the midst of an outbreak, which is a big stressor to the organization, because then besides having residents put at risk, the amount of intensity of work you have to do, the amount of communication you have to do with the public, and also your staff who might have been exposed can no longer be on the job. That leaves you with a need urgently for some backup and support so you can maintain not only the functionality and the protection of the other residents, but all the other services related to the family members who are mostly concerned and worried about their loved ones in that facility. So each one is unique, and we learn from each one a bit better, and we would like to have that continue to be improved as we progress through this one. And as a result of the change in the directive, the outbreaks are declared much more rapidly, just someone symptomatic, which we didn't do with influenza. So we'll probably hear more outbreaks. Hopefully they'll be just one person and maybe prove to be false alarms. That's okay. We don't mind that.
A follow-up?
Oh, sorry, I want to add something, which is we've had experience over the years with influenza. This is a new infection. There's no vaccine. There's no antiviral treatment that's been shown effective. So we have lots of things that we use to, first of all, prevent outbreaks, and then to try and control and prevent spread with flu, which we don't have those tools yet for this infection.
Okay, follow-up.
Thank you. Would you be able to shed any light on how long-term care homes go about deciding when a patient should go to hospital? I think we've seen I understand a number of seniors have died in the institution. Some people might think, well, if you've been diagnosed with COVID-19, you're already a resident of a long-term care home, you're 90, you should probably automatically go to hospital, but maybe there's other factors. Do you have any idea how those decisions are reached?
So it's a complicated one because they're all there with different, as you said, diagnoses and situations. Some have already put down aspects related to so-called living wills and final decisions of the family. There may be in more of a palliative type approach. There are unique situations with unique patients. I think the long-term care home usually makes an assessment, and if the physician presiding feels that this person normally would need, first of all, transfer out for diagnostic purposes, maybe for a follow-up or routine, because of the situation and potential risk, they may choose to delay that at this time if they have to go because the assessment of the presiding doctor and the administration feel this person is fully needed resuscitation and proper care with intensive use, including ventilation and things. They would transfer that person to the local hospital for that kind of care, and that's normal routine. So they're all a little different in that aspect, and that's why we have to rely upon not only the administration, but also the physician who presides over the care of that institution or the patient.
Next question.
Next question comes from Hale Cooper of Newstalk 1010. Please go ahead.
Hi, Dr. Williams. Hi, Dr. Yaffe. We heard from the province today that schools will be closed to students until May 4th. Daycares are closed until at least April 13th, but that's because under the emergency declaration, the province can only extend the closures in 2-week intervals. So just for parents' sake, do you see these licensed daycares being closed for another 2 weeks past April 13th?
So I haven't seen the details of all the aspects there. I know the schools, they decided, the Minister of Education, to delay the opening until May. And that would include for normal use, the centers at those institutions, at the schools. And that's a large part of the licensed daycares. There had been some discussion about having some opened to some capacity to cater to the needs of healthcare workers if there is much more intense impact on the healthcare system so that they can go and perform their duties and responsibilities in there. We haven't yet opened it up to that level. We've got through a large part of the 14-day quarantine period where some had some limited staffing from healthcare to complete their quarantine period, and we should be coming through that right now. We're still watching carefully the institutional side to see if they would be open to that extent. So the opening of those very much is tied to the opening of the schools, unless they're for special purposes in that regard. I'm talking about the ones located in the schools, which is about 70%. So they would have to be directed by the local boards of education and their oversight in that purpose there. And of course, directives and information coming from the Minister of Education.
Follow up.
Okay, because the province says that in large part it's taking its direction from you, Dr. Williams. So will you be directing daycares to stay closed past the April 13th deadline, so to speak, for another 2 weeks under the provincial emergency declaration?
My advice was that we had to extend beyond the initial April date because of the data we're getting information, so we're not yet through that for at least the 2-week period or beyond. The actual management administration, how that works best with the various school boards and with the Ministry of Education, is really under the purview of the Minister of Education, how that would work. The daycare centers, I said before, are a part of that whole process because they're usually located in the same buildings. They're served by the same custodial staff and other aspects that has to be taken into consideration if they're going to open up for any purpose. And of course, our concern, or my concern, would be if they're concerned that children and some who have traveled could come back in and contaminate or infect other children in the school system, they could do the same in a daycare system. And then obviously with their peers, their siblings, you could then defeat some of the long-term work that we've done so hard, and parents have worked so hard with keeping the children at home for the last 2 to 3 weeks. That would be very much a step back. So I think they're very much in concert together in that regards, and of course I will be consulting or giving recommendations and dealing with the Ministry of Education accordingly.
Next question.
Next question comes from Rob Ferguson from the Toronto Star. Please go ahead.
Hello, doctors. I wondered, now that we have 125 people in ICU, what is the capacity? Because I think on Saturday, you guys were saying that we were already at 68% capacity in ICUs.
So the data I've got here is from most of, there's about, if there's, let's say 125 in the ICU, we know that the total we have that are available at the moment is around about 3,000. So it gives you a sense of the proportion of that at this time. At least my data here says total ICU beds, 2,959.
Follow up?
Yeah, okay, that's good to know. And I'm wondering, looking ahead with this, if there's a surge, and given what is happening in nursing homes now, do you ever foresee a point where you might have to start conscripting doctors out of family practice and assigning them to either long-term care homes or to hospital? And what about foreign trained doctors? Is that even under consideration?
We have a team at their command table that's working at the human health resource aspect there, that's looking at all those combinations of how we best utilize. Right now, our family practice group are trying to really expand on their virtual care, and they've done a great job moving ahead with that and looking at all aspects in there, as well as other specialists as they continue to keep essential or urgent services going in that approach, while we've made capacity with reducing the emergency department visits and also reducing the admissions from the emergency department, of course, accordingly. And each time we keep the numbers down with the going into the institution, gives us a bit more time for preparation, whether that's getting more ventilators, our ongoing challenge always of getting more personal protective equipment, and of course looking at the HHR issues that I mentioned there with those who have come back from traveling, completing their 14-day quarantine. That would include all levels of healthcare workers, custodial, cleaning, nurses, resp techs, doctors and physicians as well, because some of the physicians move to different institutions and they'd be limited on that capacity on that basis. So if it gets down to crunch time in there, part of this committee's job is to look at how to reallocate, look at licensing, look at different aspects to be nimble to respond to those aspects. Well, it's business as usual at this state. We want to stick within the current operating mandates of those facilities, the current things with their colleges and registries as best as possible. Some of the colleges are working hard to bring back some retired people to relicense them, and that means some need to be retrained again into that to build up that bench strength and that capacity in the event it's needed. So right now we're trying to stay within the known structures we have, but when you have an emergency and situation, you're allowed to do some more reallocation as necessary. So all these people are coming forward and making their volunteerism available. We're not ignoring that. We're keeping that into account. That includes like med students, you're cleaning with residents, you're talking about IMGs, or international medical graduates, and other groups like that that we might have to utilize at that time. So all things are possible when necessary.
Next question.
Next question comes from Kenyon Wallace of the Toronto Star. Please go ahead.
Yes, hello. I was just calling to ask about the latest numbers regarding the daily tests completed. And according to what's posted now, there were 3,168 tests done yesterday. Approximately 1,370 of those came off the backlog. I'm wondering, last week we heard about this being the time when we might be able to hit 5,000 or more tests a day, but yesterday, or as of today anyway, the number is 3,168. So can you explain what's going on there?
That's a good question. And I looked at that, and our public health laboratory, which has these samples in backlog, pretty well did their amount of 1,900. They actually did around 2,100 and a bit more than that. So they did their aspect, because that's where the samples in the backlog are housed. Our external labs, by my data here, received about 970 samples, and they did them all. So it would seem that for some reason, either where it's a flow issue with samples coming in, that they did whatever came in. And was there a delay? Was there a drop in the demand? I don't have that information. So whatever came in, the external ones did manage all those. So they have no backlog still. And Public Health Laboratory did their max capacity and therefore moved the backlog down even further.
Follow up?
So, in other words, then the numbers that are posted on the website are not correct.
In what way?
You're
I think
saying
the
they've
numbers
done
you
more
gave I
tests.
agreed with.
Okay, but then you said that they did way more tests than what's posted. Like, according to the website, there were 1,371 tests that were taken off the backlog.
Correct.
But you, I think, said a larger number.
As I said, the total number done yesterday by all centers was just over 3,000. Because one thing is that the demand on the outside labs that the other day did nearly 4,000 to 5,000, they only had 973 samples submitted in to handle. So I'm not sure whether there's a delay in moving them from the assessment centers. So in a way, the number drop, part of that is because the samples, if there were more, didn't come in, or they weren't submitted, or there's a delay. It might be nice to think that there was increased or decreased demand. I would be unwilling to say that was the case this early on. So I think we have to look at maybe a flow sample issue, and we may see some different numbers again tomorrow. So in a way, the numbers you said, I agree with. As I said, the big difference is that the ones outside of the public health laboratory did not receive as many, and therefore they did everything that came in their doors, and that seems to be why it seems to be a lower number.
Next question.
Next question comes from Tavia Morrow of Hamilton Spectator. Please go ahead.
Hi, are you there?
Tavia, your line is open. Please proceed. The next question is from Brian Platt from National Post. Please go ahead.
Hi. I wanted to ask a question about, so we're entering a critical phase, we're told by pretty much everybody, where we're going to see whether we really are flattening the curve, in part because the measures we brought in about 2 weeks ago should start hopefully to show an effect now. How confident do you think we can be that we're flattening the curve if we keep the testing criteria as tight as it is right now? Because it's still only a very small percentage of people who qualify for a test based on Ontario's testing criteria.
Well, I mean, everyone who's symptomatic and goes to an assessment center, and if the assessment center deems that they have enough evidence and they're concerned that it is COVID-19, they will do the test. And we have now 86 testing sites, assessment sites. So that's a lot of opportunity for anyone who is going. Just because someone wants to do it and didn't travel, had no case contact, and are feeling quite well, we wouldn't test them in that. So I can't see that that's limiting there. They have to have enough symptoms to convince the assessment site that they need to be done. We may find with our laboratory numbers dropping down, we could do some even milder cases and looking at that as well. We still have our syndromic surveillance going on, and we still haven't seen an uprise on that. And we've seen a number of other indicators of illness and concern in our telehealth numbers, as well as calls, I should say, and in our self-assessment tool coming down as well. So I think there would be some inconsistency there if there was some other concerns in that. But I'm hoping that with our lab capacity continuing to ramp up, because we're not giving up on that, we want to head for 10 to 15,000, that we may have some opportunity to even do wider testing, perhaps in some other areas, to make sure we're not missing anything in that regard.
Follow up?
So just to clarify that then, because have you been widening the criteria? Because my understanding was having symptoms was not enough. You still needed to have some connection with travel or somebody who had a known case. So have you been starting to expand criteria, or do you expect you might do that soon?
Maybe
Yeah, go ahead.
I'll answer that. The criteria are for categories that are prioritized. The priorities, if it's a healthcare worker, somebody in a long-term care facility, a patient in a hospital who's very ill, or remote communities. But those are not the only people that should be getting tested. It's the bottom line is it's a clinical decision by the physician seeing the patient in the assessment center or wherever. And if they feel the patient should be tested, they should be tested.
Okay, next question.
Next question comes from Lisa Hefner at CHCH-TV. Please go ahead.
Hi, Dr. Williams. Yesterday I asked you about an apparent shipment of a temporary hospital from Alberta to Burlington, and you didn't know anything about it, which is understandable. But then later yesterday, Joseph Brant Hospital announced that they are, in fact, building a temporary pandemic response unit, 93 extra beds for the hospital. Is this something you're aware of now? Is this something hospitals should be doing? Is this your recommendation that they build extra capacity?
So, yes, I did check on that and understood they were ramping up some planning to say if there was such a facility, how they would work with that one there. From our command table, I had not been advised by our Ontario Health leadership in that about any other ones that they're planning to do. What we're trying to do overall is to look at all possibilities and build on different scenarios that if we have to rapidly expand using other built facilities, certain vacant facilities, and if there has to be some aspect to their temporary ones in that regard. Now the weather's getting a bit warmer. Could you do that? So all these contingencies are being put together as we speak, and mostly under the guidance and direction of Ontario Health from our command table.
Follow up?
Just wondering if you know whether any other hospitals in Ontario are doing the same thing. I didn't quite understand that.
I haven't been advised from our command table about that. It doesn't mean that those plans are not taking place. They haven't yet moved up to our command table as far as a data metric at this time. We were more looking at the other institutions that might be used or other facilities that could be used as a surge capacity for dealing with it first, because they're built, they have other amenities, washing facilities, heating, etc. This is still critical here in Ontario because while it's getting to be spring, it's not quite there yet, and so we have to look at those logistical issues.
Next question.
The last question comes from Mo Fahim at Vista Radio. Please go ahead.
Thank you for taking my question. Dr. Williams, you mentioned that you're keeping note of the state in New York and how the case number is rising over there. Would you mind just expanding more on that?
Right. We get our daily reports from our operations center that tells the overall American, U.S.-wide numbers, and then we get some breakdown as best we can from the New York numbers. Those are rapidly changing, unfortunately, and it's taking a fair amount to get the data and collect that on an updated basis. We're more watching, just because there is a common border, of course, with Ontario, and we want to be concerned about that. But at the same time, we have to watch to see can we be informed by some of the challenges they're facing, because a lot of our other comparisons when they're dealing with these type of major surges have been from Europe and other countries from Asia. Here's one right next door to us. How are they handling it? What are the logistics they're running into? What's the case fatality rate? What's the case mix rate that they're getting there? All these things are very much important for us as we look at and saying, if we're in that situation, what would we be doing, and how can we be informed by what they're experiencing there? So a number of our different people are looking at different components and trying to be informed by whatever metrics they might be giving us in the very much heat of the action.
I think this is the last question. Follow up?
And so apart from using it for comparison, are the New York numbers going to affect the precautionary measures being implemented here in Ontario?
Right now, because we have the federal travel order for anyone symptomatic or asymptomatic to be quarantined here, and most of that is, at least we haven't seen any change in the direction about like Canadians being allowed to return, and if they're Americans, how does that work there? So I feel that people symptomatic will not be coming over or flying in. The flights have decreased in that sense, and of course we would be wanting to maintain that aspect of anyone coming in will be quarantining in their home situation in that location for the 14 days. So I feel that if that's done diligently, as we assume it is, then it's not that concern to us. But of course, as neighbors, we're always concerned to see them going through such very difficult and sometimes very sad events.
We actually have the caller who dropped off before back, so please, next question.
Next question is from Tavia Morrow of Hamilton Spectator. Please go ahead.
Hi, doctors. Thanks for taking my call. I just wanted to ask you about the directives that apply to long-term care homes and retirement communities. There's another sector that is pretty vulnerable, and they're called residential care facilities. And in many respects, some of the dilemmas that the staffing issue and the close quarters that apply to long-term care homes also apply to these lodging homes where you have a lot of people with mental health issues and even elderly people. Should these directives also apply to these residential care facilities?
Thank you for asking it, and that's it must be the third or fourth time I've been asked today, not at this forum, and because it's very much on people's minds. We try to look at the wider sector, and we are trying to put out guidance documents too. You've commented there. This one has a bit of crossover to the retirement homes, but then you're talking about hospices, residential homes, various settings that are unique. They have a different clientele, different staffing, different facilities, different equipment or lack therein as far as PPE. And so we're trying to put out some guidance documents that would help them to prepare and then to respond if there's issues that would occur in their respective jurisdictions, being aware that a lot of them relate to the another ministry of a community, of MCCSS as we call it. And we're talking with them as well and consulting with that ministry in that regard, same as we're talking with the seniors ministry around retirement homes because they're under different auspices in that regard. So as we deal with all these different components, including our other ones we've talked about, working on our other vulnerable populations, be it homeless, people dealing with mental health and addictions, and different care centers, as well as our remote and rural Indigenous First Nation communities. All these ones are important. They have unique challenges, and we're trying to put out guidelines and directions as best as we can, as quickly as we can, which is a start of a dialogue of how well are they prepared, what will they do to maintain operations in the event of scenario A, B, or C, and how might they handle that, and how do we respond to support them if that event were to occur.
Follow up?
So, Doctor, when will we expect some sort of directive or guidelines for this particular sector that I'm talking about? I ask that because I think right now they're experiencing the problem with staff staying home. They're really struggling to maintain their staffing levels. They have questions about, should we allow visitors at this point? Should staff, like they have PSWs that come in just like nursing homes who are holding more than one job, should they just have one job? Those are the kinds of questions I think they have right now.
Mm-hmm. And that's what we've heard. We hope to have our guidelines out shortly. We haven't put directives, I think, because what we find at some, I guess the demographics of what's in their institution varies from place to place. Some are fairly young and relatively healthy in one event, and some are more immunocompromised and very much at risk in another one. So the difference between the two and the impact of a COVID-19 outbreak in an institution is quite different from one institution to the other. So we're trying to understand how much we'd have to do through education, knowledge, I guess assistance in times of need and ability to access that fairly quickly versus a directive that would be meaningful across the spectrum of such institutions.
Okay, thank you.